Good morning and welcome to our monthly webcast. This is session number 177 and I am Samir Mehta, your moderator. Welcome to you all from a lovely early spring morning in New York City. We have a very exciting case for you today. It is one of the heavy duty calcification strategy which you are going to require. A calcified nodule in a critical vessel causing profound ischemia. Let's show you how a combination of all the technologies, rotablation and IVL can treat this lesion. With this introduction, let me take you to the Cardiac Cath lab where Dr. Kinney and Dr. Sharma, a heavy-duty calcification strategy case. Samin, please go ahead.
Beautiful. All right, so we welcome our CCC live viewers as usual, episode number 178 and 177. These are our supporters. We disclosures, no change. So just before I start the case, I want to show that how a case makes a difference. Remember that 2 months ago, we did the case in January, actually last month, sorry, the double mini crush bifurcation. Look at the views. 40,000 in less than 3 weeks. So I'm sure the audience really got benefit and learned the technique of the 2 mini crush. In a case, long we did a rotablation and then do a 2 mini crush.
M3
was fantastic
M3
results. And then you can see the other point that we have other top in last 1 month have been as shown here. But that has always been the focus. We try to show most important, most advanced techniques and educate. Now this is the case number episode 177, 81-year-old female present with exertional dyspnea for few months and high calcium score, has a positive CT-FFR for 2 vessel disease, has controlled factors in terms of risk, and just have some proximal atrial fibrillation for which she is on dabigatran and was aspirin and dual anti-ischemic therapy with metformin controlling the sugar. EF is normal and patient has a cath done which has 2 vessel calcific disease. One is the calcific nodule, multiple nodule in the right coronary which we are going to show today, and there are 2 lesions in the circumflex which were taken care with a low syntax score. Patient got just the balloon, cutting balloon and 2 stents and 75 milligram of clopidogrel added. As you can see here, the proximal circ and the LPL distal circumflex, we got one with a mini track, then has a Wolverine and followed by balloon dilatation, then one stent distally. This was done about a month ago, then one stent proximally
Asif
with a Promus Elite, and this is the final results with excellent. So with that note, look at the LED, also very calcified, but there is a moderate lesion and it's not angiographically severe, so we have not done any functional testing, but the CT-FFR was positive only in the RCA and circumflex and negative in LAD. So we did not repeat the FFR here. So patient is here for the today's case, and Anu will take us through how does it look from the last time and what it is today. Yeah. Good, LV?
Yeah, LV is good, and here we are. The circumflex stent looks good.
Very good, yeah.
Yeah, and LAD non-obstructive but calcified.
Yep. And
So-
FFR negative.
Yes.
CT
look at it.
FFR negative, sorry.
Look at this RCA.
Look at that. This is not even tram track. I mean, this is like massive calcium. It should not be called as a severe calcium. It's a massive calcification. Now then angiogram.
So also if you see the angio,
Wow.
so
right.
likelihood, look at the how it's on the one wall, right?
Yeah.
Yep.
Calcium.
And these are the lesions which are, very high chance of perforation.
Yes.
Even whatever you do in terms of device synergy, calcium modifying strategies. So you have to be very careful. That is why we put down the step Burr and RotaTripsy approach that we probably need a 2 Burr. We'll decide which size of 2 of them, and then use a still IVL. And then, of course, the OCT guidance, right? That's a case here. Okay. So what is the
now
plan now?
if we cross, we're going to use fielder, and then we'll use fine cross. If fine cross goes, right?
Yep.
Do you still
Then we
want
go
to
with
do
the
1 to 5 Burr? We
then
go 1.5.
Yeah. If the fine cross go easy, we do a 1.5 and 2 burrs because it's a 7 French guide. Lima guide we have. We have a pacemaker because it will clearly cause the heart block. So we are ready with
Other
that.
question, once we do 1.5 Burr, then we do OCT.
Yeah,
And then
because
decide,
OCT,
do we,
because initially
go
OCT
with
will
the
not
2
go.
Burr
Yeah.
or do we go
No,
with
2 bar.
IVL?
We go with the 2 bar and then we do IVL. That done?
Yeah, okay.
Samin, you think in the very distal segment
FFR.
also there is a
Yes.
lesion, or we are just getting inadequate flow?
Which one?
I think there's no lesion.
Huh?
Yeah, just the
Yeah.
inadequate flow.
Yes.
Okay. Yeah. Well, as calcified as it gets and as severe a nodule and a very large one.
Yes. And we know this calcific nodules, there's no actual treatment algorithm yet, which we are working on based on the cases that we have done. So this is the newer generative fine cross, they call it M3. Asif, if you want to show the box. Oh,
Yeah.
good. Now that's going to a small branch.
Nice.
Yeah, I thought it'll be much harder than that.
No, that's the wire has gone. I'm not sure if anything else would go.
Yeah, but
Let's
even the
see.
the ease with which it has gone surprised me. I thought the nodule will present much more challenges.
See how we are.
With RCA.
The wire,
Yeah,
yes.
exactly. Samin,
FFR,
did you consider AL1 guide?
Yeah.
Mm,
Yeah, so, I mean,
we
this
did
particular
consider
case-
AL1 guide, but one thing I can tell you right now, we have back order shortage of so many
Yeah, we actually don't have a 7 French AL 0.75.
AL.75 guide.
Actually use a 0.75 which is not available. So we are ready with the 1.5 bar. Go ready with the 1.5 bar.
And we will go with the Rota floppy wire.
Yeah, rotor floppy.
You want to see? Look at how the wire is on one side of the wall.
Yeah. And balloon
That
ready,
is the
3.5?
reason, SS, I said we
Get
do
the
OCT and then decide maybe we don't need 2 bar.
No, we had to go step bar. We had to go very big nodule. We do a 2 bar, then you do OCT, and then you decide with the IVL and so. So this is our 2 fellows which are getting ready here. The
Chandrasekhar and
Chandrasekhar
Frank.
and Frank. All ready, eagerly. Total fellows are 9, this year 10 actually. In the interventional, kind of 9 and 1 hybrid. So program continue. As you know, by next year, the match starts. They're kind of mandating. Anu, you were able to talk to them yesterday. What was the meeting? About the match, that every center has to become interventional match now, has to be the part of it.
Exactly what
Yes.
they are doing for residency.
Yep. 3.5, 3.520. Yeah.
Well,
Yeah. Look at this calcium. This is the case where you should be ready. And I say many times we actually have the our graph master out of the closet. Be ready in case perforation occurs. Very high chance of perforation, but without that you can't do this case anyway. So we should have a 4.0 graph master out, but
3.5.
or 3.5, yeah. Because this is a very high chance. So we said we took it. So same thing like last month when I said let's do a double mini crush, such a big hit. Hopefully this one will do a lot of imaging and try to help. Now, as Anu pointed out that maybe we do a 2 bar, 1 bar then imaging. I think it's still so much nodule, which
Okay.
we know by angiogram. Ready?
Please. Okay.
Good. Yep. So we'll do that, but later, yeah.
So, I mean, how many graft masters would the hospital have used last year?
No, actually we use more,
Zero?
PK papyrus. No.
Okay.
We
No,
do have.
I mean for perforation.
Yeah, perforation. We do have cases of perforation. So I would say every other month there will be a case where you'll need. Let me pull back the wire. Wire is too far, right?
And a complete lifesaver.
Yeah, lifesaver. Yes. Yeah, we have to pull back the wire. They will pull back the wire when you are ready with the. Good. Do your things.
So, I mean, this is a 1.5.
It's a 1.5 bar. And
Okay.
we decided, yeah. Go.
Yeah, I like the, if
You
this
pull the wire
goes,
back.
Yeah, go. I'll go. Yeah. So same packing motion about starting with the 150, and if you cannot do 6-7 times, then you go to 180. You see rapid deceleration. Don't change anything. Yeah, if more than 5,000 deceleration, it will bring the empty brown triangle, and if it's more than 10,000, it becomes the filled triangle, and if it's more than 20,000, it becomes the red. Yeah. Now see the blood pressure is a little down. You show the pressure on one side. So we'll give, Will is there, and they're going to give neosynephrine.
No.
Pressure.
Hello. Put a small PNP.
Yeah. At the bottom, hemodynamics on the bottom. Yeah. Bring it on the left side.
Instead of the OCT, yes.
Yeah, good. Okay, let's go. Give 3 of neo, 3, and flush. The same 20 seconds wait. So far have made her gone through the first one.
right.
Get a connection with the 2 Burr. And
This
anytime you
is-
give neosynephrine called little bradycardia, which is usual. Yeah, good.
Okay, it crossed.
Beautiful. Yeah, beautiful.
Nice.
Anu, one of the best rotablator performed, outstanding technique. Just about every essence which you need to learn, how to not go beyond the 20-second, watch for the hemodynamics, watch for the, including the heart rate also, and beautifully done. Love to see the angiogram.
I'm just going to finish a polish run.
Absolutely. Yeah. Great technique there. You know, the managing of the wire bias, the pecking motion, the slow. Just
Okay.
And our fellows by this time are the fully expert in a rotational atherectomy. This of course has when we do the cases, we do together, but they are doing independent. Almost all of them, right? All of them doing Rota. We're doing some more training for the OA because they need to do at least 10 OA, 10 to 15 OAs in their practice. So at present, we do about 60 rotablation, about 10, 12 orbital, and about 3 to 4 laser every month.
I want to do a OCT.
Sure.
Okay, let's do those.
Samin, how has the use of
Where is the-
orbital changed with the Abbott
Yes,
vascular?
no.
Keep it coming. Yeah. Yeah. So
Where's that machine?
we have the OCT ready, right?
Why you did not have it ready?
Okay, let's do a 2 Burr then. Give the 2 Burr. Yeah. So the question comes is that how is and I'll show you the data in United States. The same way. They're both actually ours are a little different. What has happened is since the IVL introduction, the atherectomy volume has decreased by 13 to 16%. 16% of the OA and 13% of the RA. Ours have not changed. Our numbers have remained the same. One of the biggest thing is the cases which are referred to us are especially for these atherectomy. More than half of the cases come here for atherectomy purposes.
Didn't I tell you have it ready?
And it's an automatic interpretation that the
Huh?
decrease in rotational
What?
as well as orbital
No.
has been picked up by IVL, no?
IVL, yeah. This is actually, and this is very beautiful data which I'm going to show today. Yeah.
Give me the OCT.
No, but let's finish the Burr then. We can do 2 but let's take a picture first.
Okay.
They want to show first. Let's see a picture, and then we can just do a 2 Burr, and then we do OCT. Yeah, or we
No,
can do.
I want OCT right now to see what we have created.
Okay.
Okay, slow flow a little bit, which is expected. We'll give little slow flow modifying agents.
Yeah, I thought there would be more improvement in the nodule as well as with the flow, but gives you an idea of the level of calcification we are dealing with.
Yeah.
Probably the most heavily calcified lesion we have done in 177 cases.
Yeah, that is one of the most calcified. That is correct. And the key is that do you need to do this atherectomy? So I think the calcific strategy, this is the rule of 5 is coming. If there's more than 50% quadrant calcium, more than 5 millimeter length, and more than 0.5 millimeter thickness, all speaks for that you need to do some atherectomy. Now, patient requiring pacemaker. Now, why? No, then give atropine. No, please. Yeah, give atropine. Pacemaker, go to 40 or 50. Don't go higher. Because anytime you go pacemaker rate, blood pressure will go down. Make pacemaker 40 and give atropine.
I do OCT or no?
I do enable.
Huh?
I do enable.
Yeah. Should we do it or do 2 over and then do it?
Yeah, if it's close, we can check.
Huh?
Yeah, you can try. If you want, you can try, of course.
No, is that going to give us any answer?
If it's close, we can get an answer.
Okay.
Yeah, whole question comes down that if you want to avoid a second bar or what you want to
Yes.
do, that a lot of people talk about the crack in the calcium, that if there is a calcium crack, maybe that's the translate, but still there is no algorithm. And I think that we expect, I know Anu was working with the OCT team that didn't materialize further.
For what?
For the where that calcification has been, decalcification strategy have been done. You suggest to work
we are
with them.
still doing that project.
Yeah, project is
We
still
have the
ongoing.
answer. We have submitted it to ESC.
Yeah.
Nice.
Good.
Yeah. You check the path from the guide.
Hold on 1 second. You can see it good?
Yeah. and,
Okay, can you put the OCT on the side and put the blood pressure on the PNP? Picture in picture.
Yeah, please check the path.
You can see it?
Yeah, I can see it.
Are you
second.
going that side? Good.
Okay, I'm enabling.
No. Wait.
Okay, then 1 second.
Can you inject hard? Okay, start again.
You be
Yeah,
on
1 second,
fluoro.
please.
Okay. Go back. Yeah. Ready? Go.
Yeah, okay, 1 second. Enabling, 1 second. Calibrating. 1 second. Yeah, please, Cine, inject.
Go. Okay.
Yeah, beautiful image. Thanks so much. Yeah, we got an image.
Definitely there has been quite a bit of debris. Why? Because now patient has the pace rhythm. Means its intrinsic rhythm is less than 40, right? We have the pacemaker
Flush it
40.
again.
Yeah. And give full atropine. And sometimes you can always give aminophylline also if you require. Now tell us, AK, what are you seeing here?
We'll see. Now, he's just co-registration.
Yep.
Anu and Kiski, very nice demonstration of the technique of giving
Yes.
the injection and very well done.
Yep.
I hope the audience is benefiting from it. We often go straight to the tracing, but in this case, exactly how the machine prompts you when to go on cine and when to inject, just very nicely done.
Yeah, so Dr.
Okay,
Kenny-
sure, yeah.
Yeah.
So that is a calcific nodule,
yeah,
you
this
see
is
that?
exactly
Yeah.
here, the nodule on the angio, like 3 o'clock to the 9 o'clock, like more than 180, like a protruding calcium.
So we call this massive.
Yeah.
You know why massive? It's more than 90 degrees. It's almost 180 degree nodule. I don't think we have a picture. So far in so many imaging cases, we have seen one massive nodule. This is almost 3 quadrant.
Yeah, and MLD is 1.0. It's
Yeah.
less than 1.5. Very obstructive.
And
Yeah.
what is the thickness of the nodule?
That you can't
So yeah,
see.
Dr.
No, you can
Sharma,
do- yeah,
we,
sure.
we
No, no,
cannot
that-
measure the nodule because nodule consists from the not just a calcium sheet, like a thrombus or fibrin, so it has an attenuation. So we cannot measure the thickness of the nodule.
Whenever we have tried to do that, it's not possible. What you can give is that the calcium plate around it, and give us a is 360-degree calcium plate around it.
Yes, true. Like substantial
see that.
calcium.
Go there and
Jason-
show what we talk about calcium plate.
Sure,
Go.
sure. Like here, the proximal part, Dr. Sharma. So we can measure here.
Yeah.
The thickness.
When the nodule is there, it doesn't penetrate. But look at that.
Yeah.
That's the calcium we were
like
talking about.
adjacent to the nodule, the calcium thickness is 1.2, like a.
Yes.
Kiski,
1.2.
has the rotational ablation caused some cracking of the nodule or not at all?
It has.
Yeah.
It has, no? Yeah, I thought so.
Yes. You can go back there and show it, but Kiski, go to the proximal area.
Sure.
Okay, right there, right
Yeah.
there. Now, look at it. See our risk for perforation. Why are we talking risk for perforation? Is that you have almost 3.5 quadrant of calcium,
Yep.
and the rest of the area, you see that? It's not calcified.
Yeah. And Dr. Kenny,
Yeah, right there, right there.
This
Show it to
shape
them.
is shaped by the rotor.
Yeah, yeah. No, I know that we are saying, but no, I'm not talking that. Come proximal, proximal. You're going distal.
Oh, sure.
Right there, right there, right there, right there, right there.
Yeah, this is a shape like eccentric massive nodule
Yes.
just by 1.5 rotor.
See our risk for perforation. As
Yeah,
such.
still
No,
So
but
you have one quadrant, you don't see any calcium.
No, is there opposite side is not a calcium behind
Yeah.
the thick? Huh?
The opposite side is very healthy, so
Yeah.
very, very dangerous and very eccentric,
dangerous.
tough region.
Angiographically, that's what we suspected, and OCT is confirming that.
What is this?
That opposite part is, like Kiski mentioned, healthy with the risk of perforation. So, got to be very careful here. What do you suggest, SS?
Go to a Burr, yeah. And then we take a vessel size 3.5 or 4.0.
Actually, mid part is follow vessel.
So IPL 3.5 or 4.0. That's the key.
3.5.
I'll go 3.5, yeah, 3.5.
Look,
No,
although angiographically
Get ready. Yeah.
somewhat and better also slightly by OCT, still there is a, I mean, you've got a challenge ahead of you.
Yep. Yep.
This
So
is
that,
slow flow already and a lot of hard work here.
yep.
I think, and even Anu go slow with demonstrating the techniques with the 2.0. This is heavy duty calcification.
no, don't
here.
open yet.
No, ready. Let them be ready. 3.5, yes. Yeah, so this is so rare. I would say about
Connect
5%. Now we'll do hand. Yeah,
No, no.
5% of our, or 5
No,
maybe,
is it ready?
maybe 8% are ready. We'll use a step bar. This is the classical case of using the step bar. Okay. Good.
So, Samin, what precautions will you take to increase the safety here for with the 2.0? I mean, this is
No, it's the
there
same.
will be
Slow,
wire
keeping
bias.
the,
Slow.
Yeah.
Okay.
We will keep the blood pressure up. If require extra, to give it the neo, we can keep the pressure 130, 140. Yeah.
And what would be the burst speed you'll start
Same 150.
150.
So we made it, not only that, this Rota Pro, I have set it up with a company. As I said, the development of Rota Pro, I took 2 trips to the plant. So it comes set with a 150 to 155. You don't have to any tachometer, up and down. So it comes with a 150, 155 set. And if you want to increase or decrease, then you can decide what to do. Yeah. Go.
I don't like this noise.
That will be okay. Good. Okay, we are starting now.
Can you pull the wire back?
Anytime you want to advance wire, you have to press the brake. Our run through is ready? Okay, good.
Excellent. Slowly, many times watching for the deceleration and not hitting the nodule yet.
Right.
You're clearing the path.
Yeah. And we have made so many points in this tachometer that see now there is a complete, the brown or yellow, you can say triangle fill, because it was more than 10,000 RPM drop. So 5,000 is empty, 10,000 is becomes filled, and then of course when more than that it becomes the red. Good. So that tells you, because deacceleration is very important, because more deacceleration, higher is the heat generation. And that is the one trouble with the rotational atherectomy, heat.
Okay, went through the nodule.
Beautiful.
Amazing technique, Anu. Just beautifully demonstrated. Let's see the results, but I think this has been the best demonstrated IV rotablation case also in all these cases. Beautifully done.
Okay, good.
Anu, I had a feeling you would make another few passes through that.
No, but once you are gone through.
Can we show the hemos a little bit ST elevation? So I think
Right,
it is
right.
telling us we need to stop. Yeah, I think
Yes,
we've been through.
yeah.
Yes.
Exactly right.
And we can take some
It
nitrite.
could be that we have a lot of slow
Let's
flow
get the
now.
nitrite, yeah.
Yeah.
That gives
Absolutely
this,
right.
yeah. So this is the case, same, that you have to be, watch pressure, we were giving some neo, was getting better, I mean, affected, so some
Have
ST elevation
balloon
you are
pump
seeing.
ready?
Yeah, good. We expected all these findings, good.
Okay,
That's
ready?
Vinay. Yeah,
Have the run through?
yep, we are ready.
Yeah. See this.
Yeah, we expected this.
Okay. Now, no. Let's get the flow better.
Yeah.
Flush a little bit. Let's get it.
Yeah, we
better.
did quite a bit.
We
this
cannot
was-
right, right?
Yeah,
There is clearly a clearer lumen
yeah.
in the medial side of the nodule.
And particularly the proximal lesion. Proximal lesion has nicely opened up.
Has improved, which
yeah.
improved the flow.
Yep, and so still a lot of ST elevation. So I think what we need to do is rapidly do a balloon dilatation, so they increase the flow at the at the lesion. Don't do any imaging. Don't waste time. Just open the lesion right away, and that should help to decrease to wash out the debris. Now, second thing you can do is take the blood out and do an auto transfusion, like a balloon pump for the RCA only. Pull back and give it back. Pull back and give it back.
Samin, a quick question if you can answer. Would orbital be better here, saving time to change the burst sizes?
Yeah, so question was that orbital, in this particular case, I think orbital can be used, although it was a little more wire bias, so in the tortuous vessels. So this is even our, SKY consensus document came about atherectomy. When we think it's a more tortuous vessel, orbital maybe because of the wire is 0.012 inch versus 0.009 of the rota, may have a slightly higher wire bias and may cause some dissection. So yeah, but for all practical purposes, this case is okay for orbital. Start with the 80,000, see how things are, then you can increase it to 120,000. Yes. Then likely that will give rise to a little less slow flow compared to what we saw now. Okay. Let's just dilate quickly.
My worry in this case of using orbital, Samir, you've seen in the OCT, right?
Right.
No. I mean, one quadrant was normal vessel.
Yeah.
No calcium there. So you had a protruding nodule, and there's a risk of damage to that area of the vessel with orbital.
Give more neo.
Yeah.
Blood pressure has to keep going. Let's dilate that lesion
Okay,
quickly.
look at this, no lesion.
Yeah, if required, I mean, we expected, we actually were ready with this case that in the end, there may be still slight slow flow and we put a balloon pump. So now sometime you can do a very small dose of epi in the coronary, epinephrine. So take a 1 cc of epinephrine, dilute in 10 in case we need it. Yeah, I know, but give 1 epi for the slow flow. Yeah. 1 cc of epi, give it in our syringe, we'll dilute into 10, and then of that we give half cc in the coronary. No, balloon first. Right now you need to do a balloon. Yeah, good.
Okay, so that's your...
The run through, side by side. We have the rota there, and we're just going to quickly open. Short inflation, not longer, because then you cause more slow flow and no flow.
I think this is a very good idea.
And then we do IVL. We are not going with IVL because IVL require every time 10 seconds each inflation, which is too much in this vessel
Before
right
we
now.
do IVL, we need to image.
Yeah.
Let's image and see what we have created with the 2 Burr.
Good.
Okay.
Going up.
Good. Nice.
That should be all that is needed.
I don't think
Do the intervention.
Yes.
Yeah.
Okay.
Yeah, let's do it here.
Okay. Cop. I think it's. You saw how it
14,
opened up
yeah,
well.
very nicely at 14 atmosphere.
Any reason why you have the second wire there?
That's how
Just
Yeah,
for
we
more
always
support.
leave. Yeah,
More
more support.
support.
Yes, yes.
More
or
support.
Yes.
poor man's cutting balloon. So one
yeah,
one wire,
buddy
remember, buddy
Okay,
wire,
cop
and
here.
Buddy
it's
wire.
just like a score flex. Score flex has a one wire outside, and
It's
this is
a
the same
3-5.
concept. Yeah.
How are you, Hein? 20. No, no,
Yeah.
I think we went everywhere.
No, angle. Just
Little
look at
more
angle
distal
quickly.
maybe.
Yeah, just little angle there. ST
I'm
just
telling
set
you, okay, I know you want to do IVL, but we did it good with the Rota.
Yeah, see, it's not going yet.
We are not planning to go there.
No, we had to. That angle, you have done the Rota there, and there is a moderate calcium, and with a moderate lesion, I think you should
done.
cover that area with we use a 40, the 48 synergy or 38 Promus. Now take a picture now. Good.
I don't
Now
want
do
to
it
go
now,
there
do
because
the
that.
angle.
Okay, let's.
1 second. Just slow down a little bit. Not yet.
Mhm.
Not yet. Let's vessel rehabilitate before we take the picture.
Why you keep giving Verapamil? Knife
Slow.
ride.
Okay. Good. Let's
Ready?
take a picture. Yeah.
STs are still elevated, but better.
But better. Yeah.
But better.
Yep.
And you've got
See that we were thinking any further lesion. We don't have any lesion.
Yeah.
PDA is okay.
Yep.
And at the angle, I would not want to
Angle
go
always
there.
has a moderate disease. See that now it looks more roughed up because of the we did atherectomy, a lot of calcium. See, we should cover that area with a 48. We put
Okay, when we do OCT right now, we will see.
You want to do a
I don't
balloon
think-
there or no?
I would not because it's not even going.
No, it's going. It's going now. Go. It will go now. Yeah, good. Just open here 1 second and then you'll go. It's going.
OCT is ready?
Yep.
I think you have to go a little more distal there,
Yeah,
no?
we are going there also. Yeah,
And the second wire will definitely help there.
helping. Yeah.
So more suggestions here that
This is-
Stop here.
Yeah. Yeah.
do you sometimes use aminoflin here too?
Yeah. Yeah. So aminoflin, yes.
Not in this particular case. When we knew that this kind of rotational atherectomy, especially 2 Burr, you definitely need a pacer.
Yeah, pacer, atropine, and aminoflin. We have done all. So clearly that remember the whole concept of aminoflin avoiding the pacemaker is okay. You want to do it now?
Yes, yes.
Okay. And that's what we did. Yeah. So, but this case is no matter what you do, you have to come. Once you see that angiogram,
Get down.
that you have to come up in this particular case with everything possible because it's going to create a tremendous slow flow, which is expected. It's still physiological. Yeah. Good. You can
Okay,
take the Rota wire
OCT.
out now and do your OCT.
Let me get the OCT further down and then.
But ST is definitely getting better. And the most important, I would say, in this situation is management of the blood pressure. Don't let the systolic go down to less than 100. Be ahead, whatever require. You want to use epi, you want to use, we basically giving the neosynephrine, dopamine. So just keep it up.
Think we connect or do hand?
And these are just boluses, no infusion, right? We are just given the boluses here. Now, what about the ACT situation here?
Fine.
Final. Okay. Okay. Patient
I mean-
is on, yeah.
In this case, you used heparin.
No, Angiomax.
Angiomax.
Angiomax. So,
Okay.
we're still doing quite a bit Angiomax. I know a lot of people are away from it. But I think still there is a lower bleeding, particularly when we are talking about the femoral. So large bore sheath, we're still going with the heparin, but otherwise doing an Angiomax. Although we did a Bravo 2 trial using Angiomax in patients with the
Bring it closer,
valvuloplasty using Angiomax, lower bleeding. But clearly the large bore we are still going with heparin, but majority of the femoral cases and complex the PCI cases is still we using bivalvulotin in our lab.
What happened to the blood pressure?
You change it here.
Okay, good,
Yeah.
good. No, they should know.
Yeah.
Why we don't see? Okay.
As that's fine. That's fine.
Can you connect change here?
No, but that's okay right now.
You
Just
must-
finish it.
Since the
Inject
time
Yeah. Good.
Angiomax became bivalirudin and generic, it also cut down the
Take the wire out.
costs.
Take the wire out.
This is me.
We can take the rotor wire out now. It is of no value. Good. I've done the work.
Okay,
Yep.
Kiski,
Yeah,
tell
could you
me.
check the path?
And I just want
Yeah.
to say that
good.
having a
Yeah,
slow
good.
flow,
Okay.
Huh?
1
Wait,
second.
wait.
Enabling. 1 second.
No, I have it. Okay.
Calibrating. Yeah, please cine inject. Yeah, beautiful image. Thanks so much.
the slow flow is expected. Just want to tell everybody it's not a complication. We expected slow flow, but the whole game is that you can manage that slow flow. That is the case.
No, you don't see the pressure
No,
when
but
I
that's
go
okay. We are
off.
disconnecting it now. Good.
Calibrating.
Yeah. Okay, now tell us about the use of IVL versus no IVL now.
Sure.
Which we should use the IVL because no matter how much shaving you have done, it still will be a massive. It was
I
a
think
big.
OCT will show you that Rota has done a good job.
Okay.
Yeah, so
Let's
I'll
see now.
show you the,
Yes.
this is a distal
Get to the
region.
bigger screen. No.
Yeah, so yeah.
What you can do is show the OCT on the bigger screen because now people want to understand
So
that
I
are
will
we
show you
done
that like a tight
or do we
spot.
need anything more to prepare
this-
this lesion?
this
No,
cloth-
go all the way down.
Sure.
Start from below. Okay, yeah, there.
So this is the start of the pullback, like OK landing zone.
Okay.
Now coming to the proximal, kind of dark image. Still here's a obstructive. Now we are coming to the like a tightest spot. Yeah, like a much bigger ablated calcium. And yeah, we can see the, like a small fracture in the nodule, but not like a dramatic one. Like here's also some like a dissection between the fibrous plaque and the calcified plaque. Yeah, so actually much better than the after the first loaded. But as Dr. Sharma mentioned, still like a huge, like a calcified nodule burden here.
Samin, there are so many questions and recommendations I have. I think discussion as to use or no use of IVL here, I think is the real issue.
Well, I would say such a big, you tell us now, I mean, with such a massive still nodule left, although we have shaved it quite a bit, lumen is much better,
Yeah.
that you still had to do IVL?
I mean, based on the imaging, no.
Why?
You can see the cracks in the.
That I know, but
You
still,
can no. You see that you will see it. You go back to that the nodule and look how those cracks are there.
Yeah, it's true.
Yeah.
Some
See that?
like a multiple small fractures. So
Yes.
it's true there's no answer like how big fracture we can go IVL or we can skip IVL. But as Dr. King mentioned, yeah, we have some fractures.
So
Those fractures are good enough, but we will go with IVL. Yeah.
Anu, first of all, there are at least half a dozen people who have complimented you on the excellent rotablator technique and demonstrating it. The other question which has come is, what is your concern for not using IVL? And I'm reading it exactly as I read it.
Now, since we did step bar,
Show the
right?
fluoro. Yeah.
Go back. This is where I think a lot of work has to be done, and what we already have submitted our work. We cannot share yet when to do IVL or not to do IVL after any kind of atherectomy. Go back to that nodule and where we have shown that what atherectomy has done. Look at those nice fractures. See that?
Completely agree. But again, the specific question is, what would you have against it? So your answer is that there is no need.
Now, Kiski.
Yep.
So we have the nodule.
Yep.
Show again the quadrant opposite to the nodule.
Yep.
And do you see calcium there?
Yeah, actually this cross section, like a 3 o'clock to 6 o'clock is like a no plug.
No calcium.
No calcium.
Yeah.
Anyway, no plug.
So that is my concern.
Okay.
So that if you have 360-degree calcium plate, you are safe. Go with IVL, though they say that it will only work where the calcium is. The non-calcified part of the vessel, we should not have any issue. But that's my concern. Now, if you have a calcium plate across, like 360 degree, you go with IVL, and we are doing this ultrasound waves. I think we would be okay, but we'll go and do it.
Completely understand the rationale.
So that's one. Other thing is, you think Kiski 3, we opened 3.5. Give me the diameter at that level of the nodule.
Yeah, of course we cannot see here, but try to find a. Actually, the distal end of the normal part is
No, I don't give me there at the nodule. I just want that at the come back, right there. Yeah. Give me the diameter of the
yeah,
vessel.
okay. You mean MLD? Yeah.
MLD, yeah.
Yeah, it's much better. Like now 1.9. The pre is 1.0. Now
Okay,
1.9. After the
Okay,
two,
so
because
let's
you
go
did a
3.5. So
2
though the vessel size, remember what he was trying to tell us is the normal looking vessel is 4.0, but I don't think we should go 4.0. 3.5 probably will be okay. That's why I said at the tightest part where we think the IVL has to work, we are about diameter 1.0. I'm going there right now.
Okay, let's go to the hemodynamics again. Where we're going to see now.
STs are down.
Good. STs are down. And
Outstanding demonstration,
Okay.
not only of the techniques, but the hemodynamics.
Yes. So now we are going to start. Okay, Kiski, see there. Look at the angiogram, and I think that's where we are going to start, where we likely see where it is. Okay, go up.
Samin, if there is one
6,
great
6.
lesson people can learn about
Okay,
the
go.
use of rotational is it goes hand in hand with hemodynamic management.
Absolutely,
And you
very important.
Need to stay ahead of the game. Had you not monitored the blood pressure, I think you would have needed a balloon pump already.
Right. And these are the cases then patients have a bad outcome and they get away from the atherectomy.
Right.
And more, which I will show the data also, that more and more patients are being done like this, that rotational atherectomy first, then IVL. So that number, the device synergy is significantly increasing in the United States. In addition to IVL use, the most common device strategy is not orbital or laser. It's a rotational atherectomy and shockwave. We call RotaTripsy.
Look, it's been IVL has been a game changer.
Game changer.
Right.
Okay, ready for the OCT again?
Yep.
Stent 4048 synergy. Get the 4048 synergy.
So this what is that you're using there? That's the
So right now it's the IVL. We're going to 4 and 6. Yeah, 3.5.
3.5.
And you can go up to 6 atmosphere.
No, we're going 6, 4 to 6. Yeah. See, they're 9s.
Yeah.
Look, it expanded very nicely.
Yeah, very nicely.
You know, almost like you're seeing the vaporization in front of you.
Yep.
But of course, we could not go very distally with it.
Now STs are coming up, so I think we give a little breather.
Yeah.
I think what we also demonstrated is, though, you're doing a combination strategy here. As soon as we saw slow flow, we stopped the 2.0 Burr, that's one. We saw ST elevation, not slow flow, I would say ST elevation. And some hypotension, we stopped the 2.0 Burr, came out. And immediately we have to rehabilitate the vessel.
Your favorite drug.
So we gave all kind of vasodilators. When Will, the nurse in the back, is managing the blood pressure, we are giving vasodilators here.
Exactly.
If there was persistent hypotension, that's a time you stop the procedure and you have to get the balloon pump on the other side. Yeah.
Exactly the same response to IVL as the 2.0 Burr.
Yeah, so then that is why once you saw that kind of hemodynamic changes, you don't go with IVL like you saw now. When you are staying there for 30 seconds or so, it will cause more ST elevation.
Seems to have come down the STs. I
yes,
think
STs come down. Yeah, so I'll go one more. Yeah. This is also the main reason sometimes left main, when you have calcified left main.
Let's go distal area.
We have had the same issue using IVL at that time.
Go. Now you can go to 6 and then 8.
I think we are done, no?
No, we have to go distal again.
May not go now. You had one chance.
Yeah,
in the
so
beginning.
the IVL, definitely you can also, it can go through your guardzilla or guideliner. That's a good advantage.
So, Samin, would there be, let's say we were not able to go very distally, could you even downsize the IVL and maybe just go with the 3.0 there?
No, I would say that if you need to be, we use the guideliner. Go up again.
the angle, it did not make a turn.
Yeah, even other one, balloons and everything has given a difficulty, but that's okay.
That's the
It was
limitation of this balloon, IVL balloon. You see how nicely Rota made that turn at that angle?
exactly.
Okay, down.
ST is back up again.
Yep, which we expect.
So you need 1-to-1 vessel size of the IVL balloon for the sound waves to reach the vessel wall. So going smaller size, I don't think would make any effect. I'm trying to see if I go down.
Only thing, it will be the new one, and the new will have a lower profile, and chances to
Right.
go further is
I
there.
think we should be done.
Yeah,
You
just
want
do
to
one
what?
more here. Yeah,
No. Okay, the real angle we could not go,
yeah, that's okay.
but I think we did with the balloon.
Go.
This
But-
is where the nodule was.
No,
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 it's
no,
just
no,
distal
no.
now.
Now
Remember, now we are just about to the angle. Nodule, I think nodule got the good.
Kiski.
Yep.
That angle,
Yeah.
is there a lesion there on the OCT, right?
Yeah.
Go back. Go back to the OCT where we started. Yeah, right there.
See, the proximal
Yeah,
part
yeah,
of
see
the
that?
IVL balloon is where the nodule
Come
was.
down, come down,
exactly.
come
Yep,
down,
yep.
come down, come down, come down, come down.
This is also the nodule.
Yeah, but do you see a nice crack?
Yeah, come to the
Yeah, I would
proximal
not
part.
get
Yeah,
this.
we
Because
see
if
some
I need
small-
to go there now, I need a Godzilla.
Yeah, good. Let's take a picture now, and then we'll decide. Good.
Oof. Look at the way we correct the vessel.
That's okay. This is dissection. Expected.
Wire
Just-
bias.
Yeah, wire bias. That's okay. That's expected. Good. Let's get this stent now.
No. OCT to what your IVL has done. Get the OCT.
Okay, we're doing one more OCT.
Sure.
Dr.
then
Sharma
we'll do
wants an algorithm. To get the algorithm, you have to do multiple imaging to understand exactly what each device does.
So, I mean, this may be a good time to answer an unusual question. This is Dr. Nikhil Jha posting it.
OCT.
Please answer this question. Counseling points while doing PCI in an 81-year-old. In India, relatives are very scared and reluctant for procedures past 75. First of all, it's a very arbitrary distinction between 75 and 81. A good 81 could be better than a 70-year-old. But how would you answer to that, Samin?
So I think it's very simple. If the patient is mobile and doing a daily routine activities, so and the mind is good, so age is not a bar. So you can do whether it's a 96, 98, 84, 100. It's not a question, problem. We actually publish even data of the 90 plus in America. And yes, they do, age-related issues do happen, but procedural-wise, they can be done safely. So yes, basically the counseling is more important counseling to the family, that they should know what to expect. You have maybe a little more extra days in the hospital. But yes, can be, if patient really need a PCI, this is what will be the game changer in the sense that
Yep,
patient will
good
be
clearance.
more
Okay, let me do
walking,
it.
less symptoms, it's better.
Can we
So,
put the
I mean,
OCT in the big thing?
I don't know if what Dr. Jha is asking, it may even have to do with the
1 second, doctor. 1 second. 1 second.
cultural
Dr.
cultural aspects.
No, I did
the
it.
feeling is
I
that
did again.
look,
Sorry. It's too early.
Yep, that is true. So many times our patients will say, no, I don't want anything to be done. I lived my
Right.
life. That's a different story. But if
Exactly.
patient has the goodwill, absolutely we do. Yeah.
Can I do it?
Yeah, 1 second. 1 second. 1 second. I will do it. So I will enabling, calibrating. Yeah, Dr. Kenny, please cine inject. Yeah, beautiful image.
I think you've really made a far greater improvement in the lumen there, but we'll see. Dr. Jha, it may also be a good idea if this kind of a data could be obtained locally, because that would convincingly, not convincingly, but at least provide more definition and proof that. But some of these are very, very tricky questions, and I'm glad you brought it up.
Yeah.
And thank
No,
you
he's-
also
he's-
for your other suggestions. Go ahead, Anu.
No, his question was that how will he answer the family? He just had to be confident that he'll be able to do the procedure
And patient will
and
tolerate.
it.
Yeah.
Yeah. I understand what he's trying to say, because we do deal with, but in the structural, we deal that in the structural realm, the talking to the patients, because there is risk involved. As long as every risk has been discussed and they are aware and the patient is willing. So he has done his part by getting a proper consent, describing all the risks.
Yeah. So Dr.
48. Okay, now go back to where our concern was.
Yeah, this was the tightest part. Now the MLD is 2.1, and I see like a more multiple fractures after the IVL,
Look,
like inside a nodule and between the border of the plaque. Yeah, much bigger.
Go back to the angle of the nodule there. Yeah, there's a little dissection. Yeah.
Yeah, there's some dissection.
But I don't know. The one crack, maybe one extra area of fracture I saw.
Yes, true.
Right?
Yeah. Now this white
Unless
white
you
is
have a
48
randomized
millimeter.
trial assess, there's no way you will know. But I mean, based on all the experience I have had with this imaging and using both, could have done.
Anu, just looking at the images, I am quite convinced that stent expansion will now be better.
Yeah.
Yeah. Because definitely the calcium has been decalcified. Or plaque modification had taken place.
Talking. Okay, give me a
Guideliner, good.
Godzilla there.
7 French Godzilla or guideliner.
Okay, wait.
Or do you want to get a fielder wire side by side?
No. Go with the definitive therapy.
Okay,
Don't
good.
even try.
Okay, take this out then.
Okay.
Just see, you saw that angle was not made the turn with this long 4048 synergy. We expected that, but we still wanted to try first. And now we are going to go with the Godzilla.
Well, my partial solution to this was the anticipation of a need of a AL1, but I still think you would have needed a Godzilla.
Get a balloon ready. No, we can get a 404 to 30 balloon now. 403.
No, but right now to get the Godzilla down, give me the 3.5.
Yeah.
Samin, when you were talking about shortage of equipments, is it across all companies or
all companies? Every company, believe me, we are mix and matching so many times.
And they cannot even blame COVID for it now.
Nope, no.
No, this is aftermath of COVID. Yeah.
Some product
getting people back to work and having
some product is not being done, so that fiber is not available, so they cannot make the guide. I mean, there's so many things. Go up. Yep. Good. Down. You see that advance on the balloon, the inflated balloon, and now we are going to take this out.
Yeah, get that. No.
4030 high pressure. Later.
No, for what? First we're doing the stent.
I know.
Yeah. Room 1 is
not
done.
Yet, to keep it inside.
Room 1, is it done?
So the advancement of the Godzilla happened simultaneously with the balloon deflation.
Inflation, yeah, exactly. Yeah. So gradually advance, and here, I expect also another 30,000 hits on this today's case. So educational, so many steps by steps, and it's just tremendous. Sorry. Okay, this is now the 4048 Synergy XD. Because 48 does not come with the Megatron. This could be a case for Megatron also, thick struts, but it does not come in 48. You need a one long 48 stent. You may need a one extra, we'll see. Good.
We need, no?
Need probably. One probably. That you can use Megatron if you want. Ready?
No Megatron. Okay, some die.
Outstanding demonstration of Godzilla 2.
No.
Yes, okay, go up.
Go up.
And I think you'll have an absolutely
10, 12,
perfect
14,
result.
16.
Perfect result after that.
14,
This is 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. 16. And you would have constructed a brand new artery there.
1 to 16, 4 or 16?
No, 4 or 30. 4 or 30. We have 30 ready.
No,
Just,
just no.
just
We need another stent.
Do we need another stent? That's a question.
I think
Then
so.
you can take a 4.5 Megatron we have, 16
Another
or
stent
20
here.
Megatron. Use a Megatron now.
No.
Good.
Okay, ready?
Take a picture. Done. Out.
you may be done.
Yeah, you may be done.
Nice.
Although the proximal disease was always there.
Yeah, we can leave that alone.
Yeah. Good.
Okay, now let's post dilate it and then we do a
Yeah,
final
but look
OCT.
at that little dye going into the outside wall, which is part of the calcium in that at the angle. See that? Okay.
Yeah, that's a little.
That's why I
Are
think
you
do we post or leave it?
I think
con-
the
Okay,
eye looks good. Then leave it. Yeah.
What do you
concerned
think?
about
Yes, yes. Go back to that angle on the OCT.
Sure.
Now keep the balloon. We may not do
No,
it.
that's the
Keep it
question we
inside.
asked that I think we should not post.
Yeah.
We are a little bit
If it-
under expansion or there you may see
Maybe.
because of the wire bias, the vessel wall outside the stent. But I think we should leave that alone because trying to optimize here could risk perforation.
Yeah, exactly.
Yeah, so, but remember the different in the Disrupt CAD3 trial, they gave everybody 12, 16 atmosphere post, but there they did not do the Rota. This kind of case was not included because there was clear was that if you think you need a rotation atherectomy, don't enroll that case. Okay, we are ready to, what you want to do now? Because we had to talk about things.
Okay, then I'll do a quick OCT and then
let's do- show the
Kiski,
OCT.
final OCT.
Sure.
Okay.
Okay.
Can I do the injection myself? Okay, Kiski.
But enable I do.
No, go to automatic.
Yeah,
Not
but
working?
You need wait a little bit more time. So some timing is different from the old machine.
So, I mean, as the case has progressed quite expectedly, the audience has increased. Most of them are split, several saying, leave it alone.
Good. So I would say that these kind of, we really appreciate the interaction, and I know that a lot of live cases happen, but we probably, not probably, undoubtedly lead the monthly hits, which is about now 25,000 for our CCC live per month. And we thank all our viewers to really, basically continues to encourage us do the different type of cases, what they expect. And we just continue to advance the field.
Ready? Okay, Kiski, I'll be ready soon.
Yep.
Go there. Hold it.
Yeah. Now it's close.
Okay, let's go full screen. OCT.
So, yeah.
Good?
Yeah. Can I enable?
Yes,
Yeah. Okay.
go.
Enable. 1 second. 1 second. Calibrating. 1 second. Yeah. Please, Cine, inject. Yeah. Beautiful image.
We welcome so many viewers, including Dr. Luther from the UAE.
Beautiful. All right, let's analyze this OCT, then I go to my didactic.
Yes,
Yeah.
go.
Yeah. Calibrating. Confirm. Yep. I show you the distal edge first. Yep. Distal edge looks good. Like on the plaque, but no dissection, no malposition. Now come to the tightest part. Yeah. This is the, you say the curved part, like eccentric shape, but the area is like 6. Great area. And this was the tightest part, like a nodule part.
Why are you going proximal to distal?
They changed.
Yeah.
So
Now
the
come to the proximal edge. Yep.
real
no major
question,
dissection.
real question for you, Kiski, is
Yep.
whether post-dilate or leave it alone.
Because the tightest now area is 6.0, it's an optimal result. And as Dr. Kenny, Dr. Sharma
We
said,
should leave it alone.
yeah,
You see
other-
that the stent is fully opposed to the wall, though, the eccentricity index is there. That's the vessel, the way it was. And you already see there's a little bit of prolapse, which we also see it angiographically. See that?
Yeah.
Yeah, of the tissue. But we should not touch this.
This is the optimal result.
Anu, excellent question has come. Maybe we should let today Kiski answer to it directly. In case of slow flow or no flow, do you prefer OCT or IVUS?
Both should not be done.
Okay.
Yeah, agreed.
I think we made that point that when we saw slow flow, no reflow after 2 of Burr, we did not go imaging.
Yeah.
No.
You immediately have to rehabilitate the vessel
Yep.
because imaging will make it worse.
Yeah. And that's what, believe me,
At
when
that time.
I'm moderating the live cases, I tell them, they want to say, we want to see dissection. I say, hello, what it is? It's a dissection there.
Yeah.
Take care of it first that before doing it, because that's going to create a more trouble, more slow flow, more thrombotic process, and interprocedural thrombosis will go up.
I know a lot of focus is going on imaging, but I think the basic training of understanding angiography and doing PCI using angiography, we should not go away from that.
Yeah.
Because
So
when really things go sour and you think we need to make a quick decision and move fast. Remember, we always say when things go sour, which is slow flow dissection, losing the vessel, no flow on an elective case, okay, which can then give rise to VFib, and then the so-called vicious circle starts. We got to know how to handle the case. That the slow flow means you give vasodilators, dissection means go with the balloon. We may immediately have to stent the vessel if it's really, dissection of the entire spiral dissection. We have to immediately stent the vessel to get the flow back.
Samin, as you start your presentation, here is something to warm your heart and give you a good feeling. This is Dr. Luther from Dubai Mediclinic writing, welcome sir, the best educational cases invaluable. Thank you, Dr. Luther, and Samin, please proceed.
Beautiful. All right. So let's complete. We already have done the last part which have been shown.
No,
the
what
calcific
happened?
nodule
What is wrong
using
with
step
this
Burr
guy? This is the second
RotaTripsy
case?
approach. Exactly what we said. 2 Burr, then IVL, and this was appropriate by all the criteria because of intermediate and high risk finding with the positive FFR in this case and double therapy. So what I'm going to talk about, some recent international trials of the DCB ACS trial, Replica EPIC 18, TPAS, 3-month DAP trials, and best extended follow-up study. Then focus review will be the changing landscape of the calcium modification strategy after IVL, which we have spoken about, the use of calcium modification strategies during PCI after introduction of coronary IVL in the United States. So first one is our DCB ACS trial from China. Basically goal was that what if some cases you just do the DCB in acute coronary syndrome and don't do the DES, and this was a very interesting first time a trial has a primary endpoint of FFR of the target lesion at 9 months. So whole idea was that hopefully less late loss and will translate into a better outcome. And of course, routine MACE outcomes and target lesion failure was there. This is a trial of about 250 patients they started with, and OCT was used in, and IVUS used in about 1/4 of cases. And many of them, you saw the cutting balloon, scoring balloon were there, and then led to a DCB or DES, but lesion preparation occurred, as you can see, in almost 2/3 of cases. Very, very interesting. Then more importantly, that which we expect, the DES will give you better lumen. In segment acute gain was much higher with the DES compared to DCB, because residual you always will leave with some like 25% diameter stenosis, which will be about 12% with the drug coated balloon, which we know that. Drug-eluting stent. So primary endpoint was FFR at 9 months, no difference. 0.89 versus 0.90. So they say, well, we won because it was non-inferior. But to me, they didn't win. It was just okay, equal. So didn't do any much better. So both remain identical. The non-inferiority margin was 0.05 and they had 0.01. So clearly was non-inferior. Now, if you take the binary restenosis, which is 50%. You can see here 14 versus 10, no difference, but clearly slightly in favor of the in the DES compared to DCB, both in terms of in device and in segment, and more importantly, diameter stenosis. This is 9 months. Your stenosis is still about 32% in the DCB, which is about 20% in the DES. I can tell you at 15 months, DCB will be probably 40% or 45%, and DES will remain that number. So clearly it may translate into a higher restenosis, but it's a matter of time because it was done too early. Second, the point they wanted to see, what is the late loss? Is there more late loss with the DES? So it seems to be a little bit. There's clearly that higher the gain, higher the late loss, but was not that significant. Remember, rotational atherectomy trial have shown higher acute gain, higher late loss. Here, late loss is slightly higher, but was non-significant, numerically higher, but non-significant. Very interesting. So rest of the points are shown here, that there were no difference in all the points, and these are the target lesion failure and POC. Now, as you know, about a month ago, the United States, after the agent trial, paclitaxel coated balloon by the Boston Scientific has been approved, and it will be available for clinical use by May. So this we'll have a drug-coated balloon in our available in our interventional armamentarium starting within 1 month. At present, the trials are ongoing. We are actually part of the Med Alliance trial. The second one is the Magic Touch. We are part of that also. That for both ISR and now starting for the de novo. But key is the drug-coated balloon is here. Now, second is the coronary lithotripsy from Spain. The registry in the replica EPIC 18 study, multi-center. What they did is they showed, took all the patients 422 who are IVL efficacy endpoint because they have core lab adjudication, and as well as the assessment of the QCA, and 30-day endpoint is the safety. Many of these cases are done for ISR, rotational and orbital atherectomy, as you can see were there in about teens additional, and IVUS was done in about 45% of cases. So it's not that all cases were done by IVUS, but yes, we are trying to push, as AK mentioned, that you really need to do imaging to understand the mechanism and so. So what are the benefits? You see that majority of these cases, the final stenosis of less than 20% is achieved in almost 70% of cases. So very interesting, and the diameter stenosis is quite good. So it's a very good device with a combination, which is the way it has been used. Although the protocol did not mandate the way it was in the distal CAD, that you had to go every case 16 atmosphere post dilatation, like our case. We decided not to do it, but that's not usually the indication or advice is. Now they also said, let's see the effect of the IVL in acute coronary syndrome versus stable CAD. And yes, in stable CAD, event rate at about 30 days was 1.5% compared to 4.5 in acute coronary syndrome, which happens all the time, but seems to be that event rate is lower in the CCS patients and so. Now this puts it together, individual endpoints, as you can see, that patients with chronic coronary syndrome have a lower event rate compared to our acute. So expected, but overall the indications and use is very safe and gives you the good lumen. Then the question is, what is the predictor of stent under expansion? That's what we all want to know. Why you're using IVL, but stent is still under expanded. So they found a lesion length, obstruction stenosis, and baseline tight lesion, QCA. So those are the three important factors which led to stent under expansion. Of course, final post dilatation is favorable. So that really, once you use it, that basically means your stent still remain unexpanded. Like our case, we didn't use post dilatation because we had done the basic work and didn't need the post dilatation. So basically, the conclusion was that coronary IVL proved to be a feasible and safe procedure in a real life setting, effectively facilitating stent implantation in severely calcific lesion. Patient with ACS on admission showed similar angiographic success rate, but showed a trend towards higher 30-day MACE compared with patient with CCS. This was just acute 30-day data, and of course they will present 9 months and 1 year data at follow-up. Then there are 2-3 trials which have put it together that you decrease the depth duration. The T-PASS is the trial that decreased the depth for 1 month. And this is actually, you see here, the done in Switzerland, ticagrelor monotherapy, less than 1 month, not 0, but less than 1 month you had DAPT, and then second is 12 months and followed patients. So after 1 month, everybody got discontinued, some of them before. Overall 16 days. Patient got the DAPT for 16 days, aspirin, ticagrelor. Other group got aspirin, ticagrelor for 1 year. And basically, these were the patients, large number, about 3,000 patients, and basically showed that 1 month, the 12-month outcome in favor of 1 month DAPT compared to 12 months. So very, another positive message, primary outcome. And if you take only 1 month out, there is still benefit. Double, 2 versus 4% event rate at after 1 month. So it's not only 1 month, also 12 months, and it's largely driven, as shown here, the bleeding. See, the major bleeding is significantly lower in the 1 month group compared to others. So it's basically very, important. Overall, NACE is significantly lower, and aspirin was given for 16 days in this group. Second is which has been done in at Mount Sinai, Twilight, and TICO randomized trial, combined both of them, where the DAPT was given for 3 months, was stopped, and then patients were continued for ticagrelor. These were the cases, took the acute coronary syndrome, about 7,500 patients, and have the similar message, but more aggressive. In the sense, significantly lower bleeding. You can see there, although other endpoints were not different, but if you take NACE, same message. So TPAS, combination of Twilight and TICO, giving the message that 1 to 3 months of aspirin is good enough. You don't need to give further, as long as you are using the ticagrelor as the agent. Now, these are the individual endpoints which have been shown here. So clearly, among patients with ACS undergoing PCI who have completed a 3-month course of DAPT, discontinuation of aspirin followed by ticagrelor monotherapy significantly reduced major bleeding without incremental ischemic risk compared with ticagrelor plus aspirin. So this basically comes out to be all the factors in the blue are associated with the lower, higher stent thrombosis. The red are lower stent thrombosis, which we do, and we learned that now that aspirin 1 to 3 months is good enough. No need to give it for a long time. Multiple trials have that answer that question now in trials. Then we have the trial of the best trial. Best trial was everolimus eluting stent versus surgery for multi-vessel patients. And then they have 10-year data, extended follow-up, and they divided diabetic versus non-diabetic, that who really gets the benefit. See the left side, the diabetic, all the event rates are higher compared to the right side, non-diabetic. But more importantly, while the curves are kind of overlap on the right side, the left side, the curves are separated, particularly for the composite endpoints, and this is here. That you can see the PCI lost in terms of repeat revascularization, trend towards lower myocardial infarction, and then you combine death, MI, and TVR in the diabetic group, while in the non-diabetic group, all the event rates are lower, but were identical in the PCI versus CABG group. So 10-year diabetic, just like the Freedom trial, have shown extra benefit of the PCI, and this is put it together. All individual endpoints here favors CABG in terms of composite of death, MI, and TLR over PCI in the diabetic patients. So basically, in diabetic patients, multivessel disease, CABG was associated with better clinical outcomes than PCI. However, the mortality rates were similar between PCI and CABG, irrespective of diabetes status, during an extended follow-up, which is about 12 years and so. So then, lastly, we go to our focus review of the month, which we actually have extensively discussed. That is the changing landscape of the calcium modification strategies after IVL. So what we have seen, this is the data from the NCDR from April 2018 to December of 22. And this is all cases, and you can see here what is happening in the United States. From each quarter, and there are various cutting balloon in the blue, and then your atherectomy plus cutting balloon, then atherectomy alone is the brown, you can see there, and then
orange.
What?
One is orange.
Orange, okay. Orange and brown, yeah.
Burnt orange, one is orange.
Yeah. And then the IVL.
Burnt orange.
And the IVL started on top of it, which is a dark brown. So, or burnt orange. You said orange and burnt orange. That IVL really has started significantly. And what has happened? That our calcification strategy, even before IVL, were going up. Right? Because we started from 8.7, we were 11.1. But now since IVL, that has become 16. Tremendous growth or addition of the IVL into the growth. Now, many of them you see combination, atherectomy, IVL, cutting balloon, IVL plus cutting balloon, IVL, atherectomy plus IVL. The green bar definitely is continuing to increase. So what else we found? That this is very simple, that all, you see the IVL really coming big. 6.7 in last 2 years has become almost 7% use of the PCI is being done with the IVL. Now what has happened to the atherectomy? You can see the blue is the rotational atherectomy, which at peak time was about 4%, has gone down to about 2.1%. Orbital is below that, which used to be about 1.5%, has gone down to 1.1%. And then the combination, which is the blue bar, the Rota plus IVL, is now about 0.73. So combination strategies are being used more and more, and decrease in the atherectomy a little more pronounced for the orbital versus rotational atherectomy. So this is where we are. And what else we saw? There is a tremendous distribution now. Now 50% of our cases are being done with using the various strategies. So there are wide variation of the severely calcification modified approaches with the IVL or so, and these are various hospital-based data which we have with NCDR, and they have seen that there are differences in terms of the race, but more importantly, hospital in the rural versus suburban, in the Midwest, Southwest, teaching hospital versus non-teaching hospital. Clearly that the government hospital, you use more IVL, other places use less IVL. One of the big difference has been that because of the cost, very important, the hospital remain the strongest predictor of use of the IVL with the calcific modifying strategy. So now we say, well, what has happened to the complications of the calcific lesions? And remember, these are just the in-hospital complication, because NCDR just calculate in-hospital reports, only in-hospital, not even 30-day. Procedural success of the calcific lesion, we know definitely slightly lower than the non-calcific 96, the calcific about 92. But look at the significant dissection, perforation, in-hospital mortality had not changed. So our calcium strategy has improved, or increased, but has not affected any acute outcome of these patients, the dissection, perforation, and in-hospital mortality. So therefore, the conclusion was that IVL has rapidly changed the landscape of calcium modification use for PCI, although there remains wide variation across hospital. And to me, the cost of the device really makes a difference in many hospitals. So therefore, to sum up, the DCB versus DES in acute coronary syndrome, patients with 9-month FFR and MACE was equal. There's no benefit. Yeah, we did it, but I can tell you in the long term, it may be negative. Why? Because the lumen left was still quite like 30, 35% at 9 months. It could become higher with a drug-coated balloon. We don't know yet, but that's my spectrism. So therefore, I have put it plus minus. It's definitely not in one direction. Secondly, differential MACE in chronic coronary syndrome versus ACS, yes, lower complication in the CECS versus ACS, but can be used as shown there. Then 1 to 3 months DAP versus 12 months DAP of ticagrelor as on the background. ACS, absolutely thumbs up. I think you can make it even 3 thumbs up. And that actually is the guideline now. In the European Society, they have made it that after 3 months, you can safely stop aspirin. Our American guidelines are not done yet, but European guidelines are done. 3 months, you can stop the aspirin and on face of the ticagrelor. Then PCI versus cabbage in diabetic with multivessel CAD is still not good based on the best trial. Then lastly, the calcified coronary lesions are increasing due to advancing age, and the landscape of the calcium modifying strategy is rapidly changing since the introduction of IVL. Atherectomies, whether RA, OA, or ELCA, have seen the significant and steady decline since the IVL introduction, with increased use of device synergy, more so with the RotaTripsy versus OrbitalTripsy. There remains wide race, sex, geographic, and hospital variation in the use of IVL, as well as in the use of various calcium modifying strategies. Increased hospital finances of the calcium modifying devices may explain many of the observed variations. And lastly, complication of the calcium modifying strategy remains high but unchanged despite addition of the IVL. Now, the 3 questions, let me just take it to the following statement is false regarding the results of the DCB ACS trial comparing DCB versus DES, similar MACE between 2 groups, similar MI rate, higher FFR value with the DCB, similar stent thrombosis, numerically lower TVR, TLR. Answer is C, not a higher FFR, was exactly the same, 0.89, 0.90 at 9-month follow-up in this trial. Second, following statement is correct regarding the result of 1 to 3 month DAP versus 12 month DAP in ACS, except when any say except means which is wrong. There is no difference in MACE in 2 groups. There is significantly lower bleeding rates with the 1 to 3 months DAP. There is no difference in death rate between two groups, similar MI rates between two groups, lower stent thrombosis rate with 1 to 3 month DAP versus 12 month DAP, and answer there is E. There is not a lower stent thrombosis, the same stent thrombosis, but the benefit occurs because of the lower bleeding. Various kinds of bleeding. Now, the last question, following statement is false regarding the changing landscape of the calcium modification strategy since the introduction of IVL. One is, there is a significant rise in the IVL use. There is a significant decline in atherectomy since IVL introduction. Device combination strategies are increasing. Overall, procedural in-hospital complications have decreased since IVL introduction, and about 50% of the severely calcific lesions are currently undergoing calcium modification strategy. Answer is D, because complications have not decreased, remain the same. With that note, I complete my presentation for today.
Samin, outstanding presentation. Anu, you have some final thoughts on this absolutely game-changing case so far as management of dense calcific nodule. I truly want to also thank Kiski. I think this the imaging made some of the decisions possible, which completely affirms the real need for doing imaging. And of course, I want to thank our remarkable audience today, which kept us very interactive.
Okay.
Anu, any final thoughts from you or Samin?
Let's go to the OCT. Show the OCT.
Okay, she wanted to show the OCT. Go to the OCT, please.
Because I think the decision why we did not post, because we always say that we need to post dilate when there's a calcific. So if you see where we are, angiographically, we thought we saw some dye staining, right? Yeah. Which is probably because of the wire bias. So go back to the, if I go back to the angiogram, go back to the angiogram.
Have it there.
Go
no,
back.
You have the dye.
No, cannot see it. No, not there. Go back. Yeah. Can you show the angiogram?
Yeah, right there. Yeah.
We see it now.
Yeah. So this was where the wire bias was, the max wire bias. So if I go to the original picture where I synod, go next. After, as soon as we did the rota wire, go next. Go. Yeah, pull back. Next. I think I have somewhere, no? So you see, if you see the wire in the mid RCA, one side of the wall, and at the angle is at the other side of the wall. Can you see that? Are you able to appreciate? Yeah, they can.
Yeah,
Are they?
Right there.
Yes.
So therefore, it's on the other side, correct?
Are you able to see it, Samir?
Yes, absolutely.
But after we did all our work, look at the end result. We did everything, all that. Now finally balloon, actually all this done. This was a OCT. I would go back before we stented. Okay, go back here. Now see that angle, how the vessel looks at the angle, and where the vessel was in one wall in the mid RCA actually now has come to the lumen, where at the angle it is still created a wire bias and the vessel actually is opening up.
Which is okay.
Yeah, it's okay.
Most of the time, wire bias works in our favor.
Yeah, so if you see, you really see it exaggerated here. So once we did the stent, everything was, see that mid RCA looks perfect, but at the angle, it looked like maybe there is some dye staining outside the vessel wall. That is the reason we stopped, saying that don't post dilate. But if you go back to the OCT, this is where we are seeing, can now go back to the OCT picture, exactly where that is. That's that nodule, and then the swirling of the dye behind. behind the nodule. Yeah, you see that? And if you think about it, our IVL balloon did not go to that angle.
Yep.
If we had gone, maybe that calcific nodule would have been compressed a little
But
bit.
in the end, excellent results.
It came out very good. But I think the reason is same that everywhere else, the vessel, you see how the stent is nicely opposed.
Yep.
So it's indicating that you don't need to post dilate, that there will be a risk of, extravasation, probably no perforation, little bit more extravasation.
Outstanding, Anu, Samin, great job. We complete our session this time and see you during the next case, April the 16th.